Good afternoon, everyone. Dr. David Johnson here from the Back Pain and Functional Movement Training Centre. Just going to have a little bit of a discussion this afternoon about a very important topic called spinal degeneration, and in particular, I want to talk about the misinformation and misinterpretation of the data that we know about spinal degeneration. The first thing is just to talk about spinal degeneration from a radiological perspective and what we actually mean when we talk about degeneration, or when radiologists look at MRI scans and describe degenerative changes. This is an MRI scan of a lumbar spine, and here we have the vertebral bodies that make up the vertebral column. In between the bones, those little blocky bones, are the discs. These are the cushiony shock absorbers that in between every lumbar vertebral body. In the back here, we have the spinal canal. That's where the neural structures live. At the back, we have facet joints, which sort of live around here. And there's two facet joints, one on each side. And then we have this little sort of fin-like structure, which is called the spinous process. Here's the back of the skin of the back, and here's your tailbone. What we can first see on this scan is that these discs down here, these bottom two discs, look somewhat different to these ones up here. They have a different colour, and they're a little bit flattened out. They also have some bulging of the capsule of the disc here, a little bit of bulging in comparison to these ones. And these two discs have little white spots within the capsule of the disc, and these represent what we call high intensity zones, or annular fissures, or annular tears they're sometimes referred to as. And all of these changes can be referred to as degenerative. Okay, there are a couple of others as well, but they're the main commonly referred to degenerative changes that we see on MRI scans. Now, the big misinterpretation or misinformation relates to people's opinion on the relevance that degenerative changes play in the clinical presentation of pain and disability, or in the presence of not having any pain and disability. And what's really concerning is that people can have severe pain and disability, and an expert opinion might then reference these structural changes and say they're not relevant at all in this patient who has severe pain and disability. And then on the flip side, you might have someone who has severe pain and disability, and the clinician might say, well, they have significant degenerative changes, and that's responsible for the patient's pain and disability. So there's two concerning misinterpretations there. On one hand, they're not relevant in someone who has pain, and then on the other hand, they are highly relevant in someone who has pain. And all along, they're still referred to as the same thing, degenerative changes, and they look similar on MRI scans. So imagine that this patient has severe pain and disability, and we look at those and we say that's not relevant. And then imagine this patient has no pain and disability, and we then see these changes, and then extrapolate that everyone who has these changes, that they're not relevant because this person has no pain. So where does this misinterpretation and confusion stem from? It comes from these types of articles, and there's a lot of them in the literature. There's a couple that I just pulled off, and it was sort of in a recent publication as well they were referred to. What I want to bring to your attention here is that they're talking about asymptomatic cohorts of people with MRI findings of degeneration. It's in the lumbar spine and also in the cervical spine too. This study was reviewing 1,200 patients. Remember, highlighted, they're saying that these are asymptomatic populations. And what do we see in these asymptomatic populations? This is probably an easier way to look at the data summary. Across the age range, 20 up to 80, we see these changes: disc degeneration, loss of disc signal, all those things that I just highlighted in that MRI. Loss of disc height, a bit of bulging, and there's your annular fissure, facet joint degeneration. So clearly, as we get older, these degenerative changes become more prominent. And how we interpret this is really, really important, because remember, this is already a selected patient, a cohort of people that are asymptomatic. Imagine now that we went and got 1,000 people who had lots and lots of symptoms of pain and disability, and we put them in the MRI scanner as well. What do you think we'd find? We would, of course, still find these changes, right? So then we would, if we were using the same analytical approach, if every single patient that we studied had symptoms and we see all of these changes, then we would be making a similar mistake by going and saying that all of these changes are relevant in those people because they're all symptomatic. Okay. So the truth lies somewhere in between. There are going to be some people who have these changes and are asymptomatic, and there are going to be some people who have these changes and they're going to be asymptomatic. All right. So um, reconciling what it means is really, really important, and that's why I'm doing the little video, is to highlight that there is something very, very important in um, understanding and conceptualizing how to place relevance on these degenerative changes. Otherwise, it can most definitely misguide your management, and this is made clear in the statement by the authors that advanced MRI and CT are increasingly used in the evaluation of patients with back pain. The degenerative changes there are often interpreted as causes of back pain, triggering both medical and surgical interventions, which are sometimes unsuccessful at alleviating the patient's symptoms. And so that's an incorrect conclusion to draw, because they're not really the statements are not really related to each other. The fact that someone has pain and disability and you treat these structures as causation for their pain and disability, and if you get an unsuccessful outcome, it just may mean that your treatment methodology was ineffective. It doesn't mean that they're not relevant. Okay. So let's go a little bit further and really think about what is the difference between someone who has those changes and someone who does not have those. Someone who has those changes and is asymptomatic, no pain, no disability, and someone who has those exact same changes and has a lot of pain and disability. The absolute crux of understanding this is, do the degenerative changes that you can see, are those degenerative changes afflicted by inflammation? Okay. Because if you have those degenerative changes and they are inflamed, well, they will then be painful degenerative changes. If the degenerative changes that you see, like this lady, do you think she's going to have degenerative changes in her spine? Of course she is, but she's clearly highly functional. So the degenerative changes in this person's spine are not afflicted with inflammation. And so, therefore, we can rightfully say they are degenerative changes and have no causation or relationship to the patient's pain and disability. But in the patient who has inflammation within these structures, there's no way they're going to be doing those type of athletic activities. They may have difficulty just walking around the house. Okay, and there may be a lot of people in the same situation listening. If you have inflammation within these structures, those degenerative changes are extremely relevant to you because they are inflamed degenerative structures. And I try not to actually use the word degeneration in that case. I use the word degeneritis. Itis means inflammation. Okay, so tonsillitis, conjunctivitis, sinusitis, dermatitis. That means inflammation in the structure. So this is degeneritis. Of the disc in this case, if it's a super painful person. If it's someone who has no pain, we just call it degeneration and it's not relevant. So now once we've established that, we can now conclude based on the clinical assessment of the patient, which is always the first thing that we want to know, is how do you feel as a patient, not what your MRI scan shows. When we then go and do the MRI scan, if we see these changes, then we can acknowledge that there is highly likely inflammation within that joint. Okay, so the joint effectively then has arthritis, which means inflammation of the joint. And guess what? Inflammation of a joint is painful. When I implement an effective treatment strategy and I remove the inflammatory process that's associated with the joint, we can then just call it degeneration again, or we can call it arthrosis, which means there's no inflammation in the joint. The key is how do we transform someone's degeneritis back to degeneration. And that is what these graphs are all about. It is about eliminating the biomechanical stress on the joint, because the most significant factor that determines a joint health is how it moves, the proficiency with which the joint and the system of joints moves. So if we remove biomechanical stress, then we can effectively reduce biological inflammation. We allow inflammation to leave the system, and then the joint is then pain-free once again. And that's why so many people take anti-inflammatories when they get sore. They take anti-inflammatories as a means to reduce inflammation within the joint. If that wasn't the case, then we wouldn't be taking anti-inflammatories for our pain symptoms. Now, just another and final point to highlight another concept is this process of normal degeneration. So this is a graph that talks about lung health, okay, FEV1, forced expiratory volume in 1 second. And the higher your FEV1, the more powerful and healthy your lungs are. And as we age, of course, the FEV1 comes down. Okay, so as we get older, FEV1 drops down, and by the age of 75, you've lost, maybe 25% of your FEV1, but you're still completely asymptomatic from a respiratory point of view. If you're a smoker, guess what that does to your lungs? It causes an external insult of inflammation in your lungs, which then destroys the lung health slowly and steadily over time. You're not going to get symptoms immediately. There's lots of 25, 30-year-old, 40-year-olds smoking. They are hurting their lungs, but they're not aware of the symptoms until they reach a certain point, and then they start to get symptoms, all right? If I say to a smoker very early on, hey, you better stop smoking, boom, he can still live to a ripe, old, healthy age and be asymptomatic, because you then revert back to the natural history path of degeneration, okay? If I start too late and I start to get back on track at this age, I'm reverting back to a parallel pathway, but I still may get symptoms when I'm in my late 70s, okay? Now, if I overlay that on the same graph, but instead of lung function, I put spine health here, right? And the insult is not smoking, but the insult to the spinal joints is movement dysfunction. Here's a person who has no movement dysfunction. They're living a very healthy life, moving skillfully and well throughout life. And guess what? Like that old lady, even when they get to 75, even though they will have degenerative changes, they have no symptoms of pain and disability because the onset of symptoms is at this point in time. Now, someone who moves very poorly initially in the beginning, early days, they're moving poorly, they're still asymptomatic. Okay, they're still rounding their back, they're knee loading, they're breaking all the rules of functional and movement therapy and the movement therapy course that you learn when you do the movement therapy course. They're breaking all the rules, and they'll reach an age and then they'll start to get symptoms. Okay, they'll reach an age and they'll start to get symptoms. Again, if we implement movement therapy at an early stage, like here, we can get them back on track and stop this rapid deterioration. So the key point here is that we must implement movement therapy early enough so that they can still age happily with a good quality of life and not have pain and disability. If we get you too late when you've got symptoms and then you're still in your 50s or these are arbitrary ages, of course, the earlier the better. If we get you too late though, you may still develop symptoms because you cannot defy aging. There is no elixir of youth, and even once you start moving well, the body will still undergo normal age-related degeneration. And at some point, the degeneration, the structural changes may start to cause symptoms of pain and disability. All right, but really, if we look after our spinal joints and all elements of our body, in fact, if we look after them and don't put up barriers and don't insult our organ systems, including our spinal and musculoskeletal system, then we should get a good solid 100 years out of our spine without pain and disability, even though we are still degenerating. So that's the confusion that comes from the misinterpretation of this type of data. Okay, it's just silly to say that these changes are not relevant because we know that there's many people who have these changes and they have lots of symptoms. Okay, and then we also know there's many people that don't have these changes and don't have symptoms. So hope that wasn't overstating something obvious to you. It is confusing, and every single day I'll read specialist reports, medical legal reports that confuse the difference between degeneration and degeneritis and the biomechanical stress that transforms normal pain-free degeneration into painful pathological degeneritis. Okay, all the best. Thanks for listening. Talk to you next time. Bye.